No te pierdas la transmisión de las actividades del 12º Congreso de Investigación y Práctica Profesional. Suscríbete al canal de la Facultad de Psicología de la Universidad de Buenos Aires y activa las notificaciones.
Buenos días, estaba muteado, son cosas que pasan. Les quiero dar la bienvenida a este 12º Congreso Internacional de Práctica de Profesional y de Investigación en Psicología de nuestra querida facultad de la Universidad de Buenos Aires. Y quisiera iniciar esta conferencia de la doctora Sigal Zilcha-Mano, agradeciendo a la comisión organizadora y al personal técnico que colabora para que podamos realizar en estas condiciones que para nosotros son completamente novedosas, este congreso que tantos años hace que viene reuniendo a toda la comunidad que está interesada en el desarrollo de la investigación y la relación entre la investigación y la práctica profesional. Pudimos llevar a cabo esta conferencia gracias al profesor y al doctor Jacques Barber, que es decano del Instituto de Estudios Clínicos Avanzados de la Universidad de Adelphi de Nueva York, con quien trabajamos en conjunto en investigaciones sobre intervenciones terapéuticas y hemos realizado cursos y entrenamientos, realizando un intercambio entre profesoras y colegas de nuestra cátedra y equipo de investigación y profesores de la Universidad de Adelphi. Jacques Barber nos ha recomendado a la doctora Sigal Zilcha-Mano, quien es profesora asociada de Psicología Clínica y dirige el Laboratorio de Investigación en Psicoterapia y el Departamento de Psicología de la Universidad de Haifa. Ella es editora asociada de varias revistas internacionales y ha publicado alrededor de 100 artículos revisados por pares en los últimos 6 años, centrándose en la investigación en psicoterapia y la medicina de precisión en revistas líderes de este campo. A través del trabajo conjunto de estas instituciones es que hoy les podemos brindar esta conferencia donde se articula la clínica con la investigación para el crecimiento de ambos campos, retroalimentándose mutuamente. Quisiera agradecer también a nuestra colega, miembro de la cátedra y del equipo de investigación, Natalia Helmich, quien se ha tomado el trabajo de minuciosamente hacer el subtitulado de esta conferencia que la doctora Zilcha-Mano nos ha enviado con anticipación. Luego de este video ustedes podrán ver los subtítulos que ha hecho Natalia Helmich y luego podremos entrar en vivo con ella para tener un intercambio de preguntas y respuestas. Espero que sea de interés para todos nosotros y que continuemos de esta manera contribuyendo para el crecimiento de nuestro campo en donde se articula la investigación y la psicoterapia. Muchas gracias.
Hello everyone, my name is Sigal Zilcha-Mano from the University of Haifa, Israel. I would like to thank Dr. Martin Chevers for inviting me to give this talk. I'm very honored and very excited to have this opportunity to share my research with you at the International Congress of Research and Professional Practice of Psychology. The title of my talk today is the trait-like, state-like model of therapeutic change in psychotherapy research. In psychotherapy research, we have many treatment manuals, each based on specific mechanisms that are conceptualized as driving therapeutic change. We also have decades of empirical research on the efficacy of the treatments that are based on these manuals. Dozens of meta-analyses summarizing their findings suggest that these treatments are effective, at least for some of the people, about 50%. So far, not bad, right? We also have 5 decades of empirical research checking whether these treatments are effective for the reason they are supposed to be effective, their underlying mechanisms of change. And here's the problem. These studies yielded many mixed results, as has been summarized by Kuipers. Although hundreds of correlational studies have been conducted during the past decades, little progress has been made in understanding the mechanisms of change of therapies. It is as if we have been in a pilot phase of research for 5 decades, and these pilot phases cost us billions of dollars and left millions of people around the world suffering without an adequate treatment. In fact, the 50% efficacy rate that I just mentioned is exactly the same as it was 5 decades ago. We haven't moved even a bit. In this talk, I would like to suggest that one of the reasons for that is that the vast majority of literature on mechanisms of change does not give the mechanisms of change a fair chance to show their effect, but rather collapses together 2 distinct components of any mechanism of change, which may have distinct associations with treatment outcome. In this talk, I would like to suggest that any mechanism of change or mechanism of action in psychotherapy, psychopharmacotherapy, or any other mental health intervention consists of 2 distinct components: the trait-like component and the state-like component. The trait-like component refers to stable individual differences between patients before the start of treatment, whereas the state-like component refers to dynamic changes occurring during the course of treatment. These 2 components may have distinct roles in treatment. The trait-like component may serve as a common, non-specific factor or as a facilitating environment in the background of an effective treatment, whereas the state-like component may have the potential to be therapeutic in itself. Differentiating state-like and trait-like effects in psychotherapy and psychopharmacotherapy is still rare. Yet, as I would like to argue here, it is of critical importance. Disentangling state-like and trait-like effects was found to be important across many fields of science. Let's take one brief example from the field of cardiology. Here is an article from the New York Times. It was published just before the New York Marathon last year, and it asked whether marathon running increases the risk for cardiac arrest or heart attack. Findings published in the New England Journal of Medicine suggest that individuals are more likely to have a heart attack while exercising. This is the state-like effect. At the same time, people who exercise more are at lower risk of heart attack. This is the trait-like effect. The 2 effects run in an opposite direction. Clearly, it's critical to disentangle them, and we cannot infer from one to the other. If we try to learn about the trait-like effect from the state-like effect, we may reach a wrong conclusion and recommend that people should stop exercising. The methodological literature is full of studies demonstrating that we cannot infer from one of these effects to the other. Here are only several examples from the last few years, and this issue is not new. Here is an article from 1965. Moving on to the field of psychotherapy research, when we collect longitudinal data, we always collapse together trait-like and state-like effects, unless we intentionally disentangle them. In this talk, I would like to demonstrate to you how critical it is to disentangle state-like and trait-like effects using 3 examples: the Therapeutic Alliance between the patient and the therapist, outcome expectancy, and insight. At the end of this talk, I would like to speak about what I see as the most fascinating next step in the trait-like state-like research, the state-like trait-like interaction as the golden path to precision medicine. The first demonstration focuses on the Therapeutic Alliance. According to the most commonly used definition of the Therapeutic Alliance between the patient and the therapist, the alliance consists of the emotional bond between the patient and the therapist, the agreement between them on the goals of treatment, and the agreement between them on the tasks that are needed in order to achieve these goals. There are many different ways to measure the alliance, including patient self-report, therapist self-report, behavioral coding systems, and more recently, also more interdisciplinary approaches, such as the movement acoustic synchrony between the patient and the therapist, and the level of synchrony between them in their oxytocin changes within sessions throughout the course of treatment. One of the most commonly used measures of alliance is the working alliance inventory, the WAI, which is a self-report measure. The WAI consists of 3 subscales: the bond subscale, which includes items like, I believe my therapist likes me; the agreement on goals subscale, which includes items like, my therapist and I are working toward mutually agreed upon goals; and the agreement on task subscale, which includes items like, my therapist and I agree about the things I will need to do in treatment to help improve my situation. Now that we have a clear sense of what alliance is, I would like to describe to you very briefly 2 letters the 2 patients wrote to their therapist at the end of their treatments. And what I would like to ask you to do is to think about the different roles that the alliance may have fulfilled for each one of these patients. Dan's letter. In the letter Dan brought with him to one of the last sessions of his treatment, he described how insightful the treatment was for him, writing that, I found out how time and again I keep doing the same things, which made my life really miserable. What was most helpful for me was to see why I'm doing that, to understand things in a way I didn't understand before. I think this is really what made my therapy so meaningful for me. From very early in their course of treatment, I felt that my therapist was there for me, and that whatever she said was said not as a criticism, but for my benefit. And Dana's letter. In the letter Dana brought with her to one of the last sessions of her treatment, she described how meaningful the relationships with her therapist was. She explained that before treatment, she would not believe that anyone could really be there for her and with her, that anyone could understand what she called my mess ups and accept her for who she really was. She mentioned how ironic it was that the feelings that her therapist loves and appreciates her for who she really was gave her the will and the strength to make meaningful changes in her life. Please keep in mind your thoughts about the different roles that the alliance may have fulfilled for each one of these patients while we move to answer the question, why is it critical to disentangle trait-like and state-like components of alliance? One of the greatest theoretical debates in the field of psychotherapy research is about the role of alliance in treatment, and specifically whether the alliance is therapeutic in itself or not. Some argue that the alliance is therapeutic in itself, that improving the alliance would result in improving treatment outcomes. According to this position, we should focus our work in treatment on improving the alliance to achieve better treatment outcomes. But others argue that the alliance is not therapeutic in itself, but rather a common, non-specific factor in the background of an effective treatment. With individuals who are better able to form satisfying relationships with a therapist, it is easier to implement any effective technique. It is also easier to move from face-to-face to remote treatment or make any other setting changes because of COVID. According to this position, the alliance is not therapeutic in itself, but rather is in the background of an effective treatment. And the question is, which one of these positions is correct? For 5 decades, this debate remained mainly in the theoretical sphere, and empirically almost all we knew is that a stronger alliance is significantly associated with treatment outcome. Indeed, these findings were found to be highly consistent across 295 studies, demonstrating that a stronger alliance, mainly at one of the early sessions in treatment, was significantly associated with better treatment outcomes, such as changes in symptoms from pre-treatment to post-treatment. And each one of the schools of thought that I just presented to you regarded its significant correlation as providing a strong support for its own proposition. But as you may notice, this debate corresponds with the differences between the state-like and the trait-like effects. The trait-like component of alliance may refer to individual differences between patients in their ability to form satisfying relationships with others outside of the therapy room, which may affect their ability to form strong alliances with a therapist as well. It is reasonable to assume that this trait-like component of alliance may affect their ability to form strong alliances with a therapist and to benefit from effective treatment. It is also reasonable to assume that the trait-like component of alliance is thus responsible for at least part of the alliance outcome association. But this part is not what makes alliance therapeutic in itself, but rather a common, non-specific factor at the background of an effective treatment. So this trait-like component of alliance corresponds with the second position of the alliance as a common, non-specific factor in the background of an effective treatment. And it may also resemble Dan's treatment, as reflected by his letter. Dan felt that his relationship with his therapist was very meaningful for him. He counted on his therapist and trusted her. And this strong alliance served as a facilitating environment for the truly effective and therapeutic ingredients of his treatment to work, in his case, gaining insight. But there is also the state-like component of alliance. The state-like component of alliance refers to dynamic changes in alliance occurring during the course of treatment, which may bring about changes in treatment outcome, so that any improvement in alliance at one point in treatment may translate into improvement in well-being and reduction in symptoms at the subsequent sessions. If indeed there is a state-like component of alliance, and if indeed it can predict subsequent treatment outcomes, then we may suggest that the alliance has the potential to be therapeutic in itself. So this state-like component of alliance corresponds with the first position of the alliance as an active ingredient in treatment, bringing about therapeutic change. And it may also resemble Dana's treatment, as reflected by her letter. Dana felt that a relationship with her therapist was the most meaningful and therapeutic ingredients of her treatment, serving as a corrective experience for her. So if the alliance consists of both a trait-like and a state-like components, we may ask, which one of these components is responsible for the alliance outcome association? The trait-like component of alliance, so that the alliance is a product of the patient trait-like characteristics, or the state-like alliance, so that the alliance has the potential to be therapeutic in itself. Let's start with the trait-like component of alliance. Is there a trait-like component of alliance? And if so, is it responsible for the alliance outcome association? Consistent with interpersonal theories and research, findings suggest that there is a trait-like component of alliance, so that the alliance is, at least in part, a product of the patient trait-like characteristics and abilities to form strong relationships with others. There are many studies showing that. In one of the studies from our group were presentations of others before the start of treatment. So the extent to which the patient sees others as helpful, loving, domineering, submissive before the start of treatment predicted a large percent of the alliance to be formed with the therapist during treatment, up to 54%. In another study conducted by Aviv, a PhD student working with me in my lab, the acoustic parameters extracted from the patient's voice at the first 3 minutes after arrival for the first time to our clinic, way before the patient met the therapist, predicted a large percent of the alliance to be formed with the therapist during treatment. And here's a third example. The patient's domineering versus non-assertive interpersonal patterns before the start of treatment, as identified using cluster analysis on the IIP Inventory of Interpersonal Problems scores, predicted a large percent of the alliance to be formed with a therapist during treatment. So, taken together, these findings suggest that there is a trait-like component of alliance. But is it responsible for the alliance outcome association? It is still an open question what is the best way to estimate the trait-like component of alliance. One approach is to use the general tendency of that individual to form a strong alliance with a therapist, looking at the aggregated level of alliance or the main trajectory of the alliance. And this estimate of the trait-like component of alliance was found to be significantly associated with treatment outcome. But this estimate of the trait-like alliance may already be affected by the actual interactions with the therapist during treatment. So another approach is to focus on the alliance at the first session, after the first session, as an estimate of the trait-like alliance. And findings suggest that focusing on the alliance at the first session, the trait-like alliance was significantly associated with treatment outcome. But the alliance after the first session may already be affected by the actual interactions with the therapist during the first session. So another approach to estimate the trait-like alliance is to use alliance expectations. We ask patients to answer the working alliance inventory, the measure that I showed you before the start of treatment. So before they knew anything about the therapist, not age, gender, nothing. And we ask them to answer what they think their relationship with the therapist will be like. And this estimate of the trait-like alliance was found to be significantly associated with treatment outcome. These findings suggest that using different approaches to estimate the trait-like alliance, the trait-like alliance was significantly associated with treatment outcomes. In several studies we are conducting now in my lab, we're investigating the mechanisms underlying this effect. One of the mechanisms that may explain this effect is that the trait-like component of alliance of the patient may affect the ability of the patient and the therapist to be synchronized in a way which enables them to effectively collaborate and reach together good outcomes. We're now testing this conceptual model in several studies. In a specific study I would like to share with you today, we focused on the biological synchrony between the patient and the therapist, and specifically in their level of synchrony in their oxytocin changes within sessions throughout the course of treatment. We collect saliva samples from patients and therapists before and after each session throughout the course of treatment. And findings suggest that the trait-like component of alliance, as estimated before the start of treatment, significantly predicted the level of synchrony between the patient and the therapist in their oxytocin changes within sessions throughout the course of treatment, which in turn predicted treatment outcomes. These findings support the role of the trait-like alliance in treatment and suggest a potential biological mechanism underlying this effect. In this talk, I focus on the patient's trait-like and state-like components of alliance. But you may ask, what about the therapist's trait-like and state-like components of alliance? So it's not a focus of today's talk, but I will just say that therapists, not only patients, have trait-like and state-like components of alliance, but therapists do too. Some therapists are better able forming satisfying relationships with others outside of the therapy room. And these therapists are better able to form strong alliances with our patients as well. And their patients are more likely to have better treatment outcomes. So taken together, these findings suggest that there is a trait-like component of alliance and that it is responsible for at least part of the alliance outcome association. But what about the state-like component of alliance? Can alliance also be therapeutic in itself? Findings suggest that there is a state-like component of alliance. Even when patients say that they don't understand why we're asking them to answer the working alliance inventory after each session, although they don't feel that the alliance is changing so much. When we look at the data, we see that the alliance changes from one session to the next, and also within sessions when we use behavioral coding systems. Findings further suggest that these state-like changes in alliance can predict subsequent changes in treatment outcomes. So these findings suggest that the alliance can predict subsequent treatment outcomes. But we can ask the question whether the alliance can cause changes in treatment outcomes. In order to establish causal relationships, we need to show that it is possible to manipulate state-like alliance and that manipulating the alliance results in subsequent changes in treatment outcomes. So is it possible to manipulate alliance? And if so, does it result in changes in treatment outcomes? Findings by Paul Christoph and his group and Chris Moran and Jeremy Safran and their group suggest that providing therapists with training on how to improve the alliance indeed result in stronger alliances, less dropout, and almost significantly better well-being for the patients. Another question that we can ask is whether it's possible to manipulate the state-like alliance effect on outcome. What does it mean to manipulate the effect of the state-like alliance on outcome? Let's say that 1 point improvement in the alliance at one session predict one less symptom at the next session. The question is whether we can make this effect stronger so that any 1 point improvement in the alliance at one session will result in 2 less symptoms the next session or 3 less symptoms the next session. This is exactly what it means to manipulate the state-like alliance outcome association. And findings suggest that it is possible to manipulate the state-like alliance outcome association. For example, providing therapists with feedback on how to improve the alliance makes the alliance outcome association stronger, so that if we allow therapists to see how their patients responded on the working alliance inventory at the previous session, it makes the alliance outcome association stronger. Also, providing therapists with training on how to identify alliance ruptures and how to improve them makes the alliance outcome association stronger. So what can we learn from these studies? Taken together, these findings suggest that the alliance consists of 2 distinct components, the trait-like component and the state-like component, and that each one of these components is responsible for different roles in treatment, so that the alliance can be both a common, non-specific factor in the background of an effective treatment, but may also be therapeutic in itself. The second demonstration focuses on expectancy, outcome expectancy. Outcome expectancy refers to the individual's belief about whether and how much they will improve as the result of treatment. Here are two items that are commonly used to measure expectancy in the treatment of depression. The first item: I believe the chances of my depression being completely better at the end of this study are ranging from very poor to very good. And compared with now, I think my depression at the end of this study will be ranging from much worse to much better. In a recent meta-analysis based on 81 studies, higher levels of expectancy were found to be significantly associated with better treatment outcomes. But the effect size was small, R equals 0.18, with much variance, so that in many of these studies, the effect of expectancy on outcome was not significant. This small effect is surprising. It is smaller than we may anticipate based on many studies in many fields of science demonstrating the profound effect of our expectations. But what happens when we disentangle the state-like and trait-like components of expectancy? The state-like and trait-like components of expectancy may have different roles and different meanings in treatment. The trait-like component may refer to individuals' general tendency to expect treatment to be effective for them. These general tendencies may be a product of other trait-like tendencies of the individual, such as level of optimism. But there is also the state-like component of expectancy, which refers to dynamic changes in expectancy occurring during the course of treatment. Findings based on machine learning implementations suggest that the trait-like component of expectancy is at least in part a product of the patient trait-like characteristics, whereas the state-like component of expectancy could not be predicted based on the patient baseline characteristics, at least not those that we had available in our studies. Findings further suggest three main trajectories of state-like expectancy development throughout treatment. Some individuals show no state-like changes in expectancy throughout the course of treatment, so that the trait-like component of expectancy dominates the whole course of treatment. The red line, 38% of the sample. Other individuals show increasing expectancy until mid-treatment, followed by decreasing expectancy until the end of treatment. The green line, 36% of the sample. Still others show gradual improvements in expectancy throughout the course of treatment. The blue line, 26% of the sample. And what about the ability of expectancy to predict treatment outcomes? When we did not disentangle the trait-like and the state-like components of expectancy, we found a small, non-significant effect, very similar in size to the one that was found in the meta-analysis. But when we disentangled the trait-like and state-like components of expectancy, we found that the trait-like component of expectancy was not a significant predictor of treatment outcome, whereas the state-like component of expectancy was a significant predictor of subsequent treatment outcome. These findings suggest that it is possible to establish a correct temporal relationship between state-like changes in expectancy and subsequent changes in treatment outcomes. But is it possible to establish a causal relationship between expectancy and outcome? In order to establish a causal relationship between expectancy and outcome, we need to show that it is possible to manipulate expectancy, and that manipulating expectancy results in subsequent changes in treatment outcomes. So is it possible to manipulate expectancy? And if so, does it result in changes in treatment outcomes? In one of the few studies that manipulated expectancy in the treatment of depression, Brett Waterford from Columbia University in New York randomized individuals to two groups. The first group, the high expectancy group, was told that they are being assigned to open trial SSRI, so they have 100% chance of receiving SSRI. The low expectancy group was told that they are being assigned to placebo-controlled SSRI, so they have 50% chance of receiving SSRI. They then compared only those individuals that actually received SSRI. And they found that those in the high expectancy group had better treatment outcomes than those in the low expectancy group, although all those individuals actually received SSRI. They also found that these state-like changes in expectancy significantly mediated the effect of expectancy manipulation on treatment outcome. Specifying the effect of a mechanism of change, in this case expectancy, on outcome, enables us to investigate the neurobiological mechanisms underlying this effect. In a follow-up study of the one that I just presented to you, we were interested in investigating what happens on a neurobiological level when we manipulate expectancy. And we found that manipulating expectancy results in normalization of the amygdala hyperactivation to sad phases, which is typical for patients with MDD. We also found that these state-like changes in amygdala activation significantly mediated the effect of expectancy manipulation on treatment outcomes. The third demonstration focuses on insight, and specifically insight into one's repetitive, maladaptive interpersonal patterns. When I prepared the slides for this talk, I debated whether to use this slide or this one. And I thought that maybe we have enough graphs in this PowerPoint and that this dog may get more credit. So when focusing on insight, we may want to ask, is a high level of insight good or bad for psychotherapy that focuses on improving insight? And the answer is, it depends. If we focus on the trait-like level, the association may be negative, so that individuals with poor levels of insight may benefit the most from psychotherapy that focuses on improving insight. Whereas in the state-like level, the association may be positive, so that gaining insight may result in subsequent gains in treatment outcomes. The graph that I showed you at a glance before is a bit more complicated because we focused on the agreement between different informats reports on the level of insight, so to be able to better capture the complexity of this measure, this construct. This table summarizes the three examples and hopefully demonstrate how critical it is to disentangle state-like and trait-like effects. Disentangling state-like and trait-like effects of alliance, it becomes clear why the alliance is the most consistent predictor of treatment outcomes. Because both the state-like and the trait-like effects are significant and move in the same direction, both are positive. One of the advantages of disentangling state-like and trait-like effects of alliance is the progress toward precision medicine. We're able to reveal the different roles that the alliance may fulfill for different individuals and in different treatments. I will give a specific example in a few minutes. Disentangling the effect of insight on outcome, it becomes clear why the why the mixed results on the effect of insight on outcome exist in the literature. Because both the state-like effect and the trait-like effect are significant, but they move in opposite directions, so that the state-like effect is positive, whereas the trait-like effect is negative. Disentangling trait-like and state-like effects, it becomes clear why the effect of expectancy on outcome is small and not significant in many of the studies, because the state-like effect is positive, whereas the trait-like effect is not significant. For me, the most fascinating next step in the trait-like, state-like research is studying the state-like, trait-like interaction. Why? Because I believe it is the golden path to precision medicine. Let's revisit the example that I gave you at the beginning of this talk about the effect of exercise on the risk for heart attack. Another piece of information that we may want to consider is that findings published in the New England Journal of Medicine suggest that the state-like effect that I presented to you, that individuals are more likely to have a heart attack while exercising, is limited only to those individuals that did not exercise on a regular basis. So that the effect of state-like exercise, the state-like effect of exercise on the risk of heart attack was moderated by the trait-like component of exercise. So the most important variable here is the trait-like, state-like interaction. In psychotherapy and psychopharmacotherapy, the trait-like components may identify the subpopulations who may benefit the most from driving state-like changes in a specific target. Let's look at several examples from the research on alliance and on expectancy. Focusing on alliance, we may anticipate that individuals with poor levels of alliance may benefit the most from driving more state-like changes in the alliance. And findings indeed suggest that driving state-like changes in the alliance is most effective for individuals with poor trait-like abilities to form a strong alliance before the start of treatment. So the most important variable here, again, is the trait-like, state-like interaction. On your left, you can see those individuals with high trait-like alliance, whereas on your right, you can see those with poor trait-like alliance. For those individuals with poor trait-like alliance, they may benefit the most from driving more state-like changes in alliance, the blue line, in achieving better subsequent treatment outcomes, so lower scores on the y-axis, which is symptoms. These findings are based on correlational design, where we identify the state-like changes in alliance using cluster analysis, the first 4 sessions of treatment in predicting subsequent treatment outcomes. We're now testing whether we can replicate these findings using 2 studies in which we implement experimental designs. Focusing on expectancy, the example that I gave you before, that expectancy manipulation resulted in normalization of the amygdala hyperactivation to set phases, which in turn predicted treatment outcomes, focused on the sample level. But if we're interested in precision medicine, we may want to ask who are the individuals who may benefit the most from state-like changes in amygdala activation. And findings suggest that here again, the trait-like, state-like interaction was the most important variable in predicting treatment outcomes. So driving state-like changes, state-like reduction in amygdala hyperactivation was most effective for individuals with highest trait-like activation at baseline. Similar findings were found regarding pallidum activation in response to reward cues. Again, the million-dollar question is, who are the individuals who may benefit the most from state-like changes in pallidum activation? We used the same design as I presented to you before. So individuals were scanned twice while doing the MIDT task, which is a reward-based task. The first time in baseline, so we were able to estimate their trait-like level of pallidum activation, and then a week after getting the expectancy manipulation and before the start of treatment. So we were able to estimate the state-like changes in pallidum activation. And we found that people differ in their trait-like level of pallidum activation. Some showing hypoactivation of the pallidum and some showing hyperactivation of the pallidum. Findings further suggest that this trait-like level of pallidum activation determined who are the individuals who may benefit the most from driving state-like changes in pallidum activation, and also the specific direction of the changes that are needed. So for those with low trait-like level of activation, driving more state-like increases in the level of activation was most beneficial. Whereas for those individuals with the highest trait-like level of activation, driving state-like reduction in the level of activation was the most beneficial. Taken together, these findings are consistent with the homeostasis assumption. So identifying the trait-like components which signal a disruption in the level of homeostasis may pave the way for devising custom-tailored interventions for specific individuals. We are now testing the trait-like state-like interaction in 3 ongoing randomized control trials. 2 studies in which we examine whether individuals with poor alliance at baseline, trait-like alliance, may benefit the most from driving more state-like changes in alliance. In one of the studies, we compared 2 psychotherapies, one that focuses on improving alliance, so producing state-like improvements in the alliance, and the other, which we're conducting in collaboration with Dr. Brett Waterford from Columbia University in New York. We compare SSRI and placebo while manipulating the number of visits with the physician. In a third randomized control trial, we examine whether the interaction between the level of disruption in the mechanism of change at baseline by the changes in that mechanism throughout treatment may best predict who are the individuals who may benefit the most from any treatment. So I've reached the point of this presentation where I want to say thank you for all of those that contributed to these studies. And also, to thank you for listening to this talk. And I would love to hear your questions, thoughts, and suggestions. Thank you.
Hola a todos. Bien, hemos terminado la transmisión de la presentación de la doctora Sigal, que está aquí con nosotros. Nuevamente estaba muteado y no se podía escuchar lo que decía. Así que mi agradecimiento a la doctora Sigal Zilcha-Mano, al doctor Jacques Barber de la Universidad de Adelphi, que es miembro de la SPR y que de alguna manera lideran y conducen la investigación en psicoterapia de una manera tan abierta que nos permiten a todos producir más cada uno en nuestro campo, y están con nosotros parte de la cátedra y del equipo de investigación. Si le podemos dar ingreso a Natalia Helmich, estudiante doctoral, que laboriosamente ha hecho la traducción para que podamos contar con el subtitulado, y tenemos también a la doctora Rita Ragau y a la magíster Pia Bernengo, a quienes les damos la bienvenida. Sigal, thank you so much for your contribution to our conference, and we are really glad to have you here.
Thank you, Martin. I'm really grateful to be part of this conference. I only wish I could be in person now in Argentina. Thank you.
Thank you so much. I know the effort that you have made to be here with us, because there is a time difference, very, very considerated. So we can do some questions to you, if you agree with that. Pia. Estás muteada. Rita.
Me desmuteé. ¿Hacemos las preguntas en castellano o en inglés, Martín?
Me parece que sería bueno en castellano, en español, y Natalia puede traducirlas. O si no, las podés hacer bilingüe vos directamente.
En dos. Yo tenía pensado una pregunta, pero viendo el chat, hay una pregunta más general sobre lo interesante que ha resultado la diferencia entre componente del rasgo y componente de estado sobre la alianza, y hago esta pregunta general, que es si esto le ha servido también a los clínicos para el trabajo, el aporte de la investigación a los clínicos en el trabajo con los pacientes. Hi, Sigal. I am Pia Bernengo, and I have questions, but I read in the chat that people were very interested in the two components, and they didn't heard a lot about the trade-like and the state-like. So if you want to talk a little bit more about this. And another thing is if you have results about if clinicians could benefit about this study about identifying both trade-likes and state-like.
Thank you for the question. Yes, I think that many times we say that the alliance is important in many different studies and in our clinical practice, but then we ask, what can we do with that? So we know that the alliance is important, but is it important because the patient is able to establish a good alliance with us? He just came to treatment with just very good abilities to form good interpersonal relationships, or is it because something that we need to do in treatment? And I think that these three, state-like model, differentiate the two. It asks who are the individuals who come to treatment with those abilities, and we don't need to spend a lot of time in treatment in order to establish them. And who are the individuals that actually need this time in treatment to form a very strong alliance because they are not coming with these abilities. I think that many times in psychotherapy, we say that there are those common factors that are important to any patient. But when we meet a patient, we need to make decisions. We need to make a decision whether to focus on a specific mechanism or another mechanism, whether to use specific techniques or other techniques. And I think that this entangling the trade-like and state-like components make us better able to do these decisions because we meet the patient. We're trying to understand which common factors are those, or even those specific factors are those that the patient is already very good at. For example, able to form strong alliances, satisfying relationships with others, and which components, which mechanisms, which factors are those that this patient is most in need in doing substantial work with. And I think that...
Sorry, sorry, Sigal. I need to translate your answer. So Could you repeat, because I I don't remember all your.
Yes, I'm sorry, I forgot.
It's okay.
So I think that when thinking about the importance of disentangling trait, like in state, like
Cuando se piensa en la importancia de desenredar el efecto, los componentes de rasgo y de estado,
one is better able to make decisions in treatment.
Es mejor pensar en qué beneficia el tratamiento.
So we know that the Therapeutic Alliance is important in any treatment, using any technique or any method.
Sabemos que la alianza terapéutica es importante en cualquier tratamiento, utilizando cualquier método.
But still we meet this specific individual and we need to make decisions how to work with that individual.
Pero igualmente tenemos que hacer hincapié en la importancia de las personas, del individuo.
We may use the alliance as a background to doing other things, so to have a good alliance to be able to implement many different techniques that we want to implement.
Utilizamos a la alianza en el fondo del tratamiento para poder aplicar las técnicas.
Or rather, do we need to actually put a lot of time in treatment and efforts in trying to establish a corrective experience with that patient?
O, por otro lado, nos tomamos el tiempo necesario para establecer la alianza con el paciente.
And disentangling the state-like and trait-like components help us make exactly those decisions in treatment for each individual.
Y poder desenredar el efecto de rasgo y de estado nos va a permitir poder trabajar con esos pacientes y con cada individuo.
I'm not sure whether it answered that question. I can speak for hours on that.
Si respondí esa pregunta, podría hablar por horas sobre esto.
Yes, it's interesting to take time to focus on what you mentioned. Es importante poder ponerlo en foco para que miremos esto en los tratamientos.
Quisiera hacerle una pregunta, si es posible. May I ask you? Hello, Sigal. Thank you for being here with us. La voy a hacer en castellano y Natalia, vos, por favor. ¿Qué relevancia le da y qué importancia le da a los factores de la persona real del terapeuta en los efectos o los resultados del tratamiento psicoterapéutico? Los factores de la persona real del terapeuta.
¿Cuánto pesan los factores, las variables del terapeuta, las características?
Exactamente, de la personalidad del terapeuta, ¿no?
Okay, Rita asked how much the characteristics of the style of the therapist affect in the therapy.
This is a good question. I think that the therapists also come to treatment with their own trait-like and components or characteristics. Should I wait for the translation or should I?
Es una buena pregunta. Sí, nos tenemos que preguntar cuánto influyen las características del terapeuta.
And then when we speak about, as you said, personalizing the treatment to the individual, we need to speak both about the patient and the therapist.
Y cuando hablamos de personalizar el tratamiento para las personas, tenemos que focalizarnos en los dos, tanto en el terapeuta como en el paciente.
And take into account both the patient and the therapist trait-like components and characteristics while making decisions about this specific diet, therapeutic diet.
Y tomar en cuenta a las características y a los componentes de estado y de rasgo del paciente y del terapeuta nos van a permitir poder tener y recopilar información de los tratamientos y poder hacer un tratamiento adecuado para los pacientes.
Perfecto. Gracias.
Natalia, hay unas preguntas acá en el chat que podemos pasarle.
No
Sigal,
las-
there are some questions that people who are watching you now had made, so if you can answer that.
No las veo a las preguntas yo en el chat.
¿Vos, Pía?
Sí, las pusiste vos, Martín. Ahí,
Sí.
Sí, la lea. Una es, some people ask if the studies are made only on patients or too on psychotherapy.
Sorry again, whether the studies are based on...
Are made on patients, as you say, and also on therapists.
Whether the disentangling of the components is relevant for
both components.
Yes, absolutely. I think that if we want to make any decision or therapeutic decision about a specific diet, it's important for us to take into account both, because something may be very helpful for the patient, but this specific therapist may not be able to deliver that in a way that we may think that may be good. And so everything should be matched to that specific diet.
Sí, por supuesto. Se hacen también sobre los pacientes, no solamente sobre los terapeutas, porque esa es la única manera de poder hacer un tratamiento especializado y una terapia especializada para esas personas.
Another question from Paula says, how long does it take to disentangle both state and trait factors in your opinion? Is it possible to achieve in the first session?
That's a good question. It depends on how much we think that the specific construct has its dynamic pattern. So,
es una buena pregunta. Va a depender de la dinámica que tenga estos dos factores.
For example, if we're interested in trying to understand what the individual patient is coming with to treatment in terms of interpersonal abilities, as opposed to what is formed with a therapist during treatment.
Tenemos que tener en cuenta también cuáles son las habilidades interpersonales que tiene ese paciente durante el tratamiento y evaluarlo en relación con el terapeuta.
So we may have a good understanding of what the patient is bringing with him or with her to treatment in terms of interpersonal characteristics and other things, or we may try to make these decisions based on, in some of the outpatient clinic, the same patient is seeing different therapists or...
Entonces tenemos que tener en cuenta las justamente las habilidades interpersonales que tiene este paciente y qué trae a la terapia.
But I think that all those are really good questions that the research, this field of research is only now coming into trying to answer them. So these are great questions.
Y esa es una muy buena pregunta porque nuestra investigación está intentando arribar a poder responderla.
Leo otra pregunta, Martín.
Dale, es de una colega, Nora Sigal.
Nora Sigal. Nora Sigal asked, why did you call the black box? It's okay.
So, how black is that box right now?
I think that 5
Caja.
decades of empirical research on what works in psychotherapy. And we know a lot, and still we don't know enough. And I think
porque todavía no sabemos lo suficiente, más allá de que hay muchos estudios, todavía no lo sabemos.
And I think that one of the reasons for that is that we sometimes combine together different components of the same contrast that may have very different meanings in treatment.
Y lo que tenemos que tener en cuenta es que justamente esto, la unión de estos componentes, la dinámica de estos componentes, hace que haya distintos resultados.
And one of the examples is the Therapeutic Alliance. So there is a big contrast between those individuals that come to treatment with those abilities, and we can just count on them, and those individuals with whom we actually need to do a lot of work to be able to form strong alliance.
Y uno de los componentes que tenemos que tener en cuenta es a la alianza terapéutica, porque justamente no es lo mismo una persona que venga con habilidades interpersonales a la terapia, en donde vamos a trabajar de una manera particular, a pacientes que no lo tienen tan desarrollado.
¿A otra pregunta de Leandro?
¿Podemos?
Bueno, Leandro asked if the expectation about treatment and the Therapeutic Alliance is improved with the IRSS, and why are improved?
The IRSS is the SSRI for you, the serotonin.
So I just want to make sure that I understand the question. So whether treatment that is based on providing patients with SSRI actually improve expectations?
Yes.
So when we did not disentangle the stay-like and trade-like component, it was hard to find any effect. But when disentangling them, it seems that some of the individuals actually improve a lot in their expectancy during the treatment.
Algunos de los pacientes mejoran con el consumo de los recaptadores de serotonina y poder desentrañar o separar los componentes de rasgo y de estado también ayudan.
Well, I think that Dr. Sigal, if you want to add some comment or anything you want, you can do it now. And we appreciate your time. So we can finish this space. And thank you so much again.
I mainly want to say thank you. The questions were great and just exactly those issues that are the greatest debates and open questions in the field. So I appreciate the questions and I appreciate the opportunity to give this talk. And I hope to see all of you in Argentina post-COVID whenever it's possible.
Quiero agradecerles también a todos por la invitación. Las preguntas fueron muy precisas y me gustaría verlos a todos también en Argentina después del COVID.
Therapeutic Alliance is one of the strongest topics that we teach. And Pia and another colleague, Marina, were in Adelphi last year, I believe, working and learning with Jacques Barber in the Multi-30. And we really appreciate your contribution, and it's great for us to have you here. So we will invite you for the next year, we hope, in person. Thank you so much.
Thank you very much.
Gracias a todos por estar con nosotros. Gracias particularmente a Natalia, que ha hecho el subtitulado y la traducción, y es una experta ya en la traducción de la doctora Sigal. Gracias a todos los que están interesados en la psicoterapia y la investigación en psicoterapia, para que podamos mejorar no solo nuestra enseñanza, sino nuestra práctica y llevar mejores resultados a las personas a las que tratamos. Gracias a la Universidad de Buenos Aires y a la SPR también, que es quien nos agrupa y nos conecta. Gracias, Pia. Gracias, Rita. Y nos veremos la próxima. Adiós.
Gracias a todos.
No te pierdas la transmisión de las actividades del 12º Congreso de Investigación y Práctica Profesional. Suscríbete al canal de la Facultad de Psicología de la Universidad de Buenos Aires y activa las notificaciones.